Hello, everyone, and welcome to this WomenHeart HeartTalk focused on blood pressure and more specifically, how high blood pressure or hypertension impacts women across their life course. I'm Celina Gorre, and I am the CEO at WomenHeart, and I'd like to thank you for spending this hour with us. Today's session is being recorded, and also we will have some time near the end of our hour together for some Q&A, so please do submit your questions at any time. And remember that this discussion is educational and is not a substitute for personal medical advice. For anyone new to us, WomenHeart is the national patient-centered organization for women living with or at risk of heart disease. We support, educate, and advocate through trusted resources, peer-led support networks, and our trained WomenHeart champions to advance equitable, high-quality care in every community. We are the leading patient voice in women's heart health. We are so grateful to our supporters, especially AstraZeneca, for making this program possible. So let's get right into it. Blood pressure plays a significant role in heart disease and affects many other body systems, yet it's often misunderstood because it can be silent. And even when you feel fine, it can quietly impact the heart, the brain, our kidneys, our eyes, and even our entire body during pregnancy. This program is part of our effort to bring more attention to hypertension and help people understand what the numbers mean and what can be done about them. Knowing your numbers and how to act on them can prevent serious problems long before they start. We are joined today by our expert speaker, Dr. Ijeoma Isiadinso, as well as two wonderful WomenHeart champions, Kina Lucombe and Carrie Stroll, who will help us connect the dots by sharing how hypertension has shown up in their own lives. And over the next hour, we'll start with Blood Pressure 101, what it is and how to measure it, clarify what counts as normal, elevated, and high, and talk about risk factors and how hypertension shows up across a woman's life before we discuss how lifestyle changes and treatment can help. After our clinical discussion, we'll hear more from our champions and move into our audience questions. So let's jump right in and introduce our clinical speaker. Dr. Ijeoma Isiadinso is a preventive cardiologist and the medical director of the Emory Center for Heart Disease Prevention. She is board certified in general cardiology, nuclear cardiology, and echocardiography, and has dedicated her career to helping women lower their cardiovascular risk through prevention, early detection, and education. She co-leads the Familial Hypercholesterolemia National Awareness Campaign with the Association of Black Cardiologists and was a writing group member of the upcoming 2025 ACC-AHA guideline on acute coronary syndromes. Dr. Isiadinso is also a nationally recognized speaker on lipid disorders, cardiovascular risk reduction, and women in heart disease, and her research focuses on addressing disparities in care and improving community health. Dr. Isiadinso, it's an honor to have you join us today for this conversation. We are looking forward to learning from you, from your expertise, and exploring this topic together. Over to you.
Celina, thank you for that introduction. I am so pleased to be here with you, our WomenHeart champions, and our attendees to talk about blood pressure in women and why it matters. So first, I'd like to just start by just identifying what blood pressure is. Blood pressure is when the heart pumps blood through the arteries and it applies pressure against the walls of the artery. And this is what blood pressure is. As you all know, when you check your blood pressure or when it's checked in the physician's office, there are two numbers that are obtained, the top number and the bottom number. The top number is what is known as systolic blood pressure. It measures the pressure of the blood pushing against the artery walls when the heart is beating. The diastolic blood pressure is the bottom number, and that measures the pressure of the blood pushing against the artery walls in between the heartbeats, so when the heart is at rest. So whenever you go to your doctor's office and you are getting blood pressure readings, you should know what both of those numbers are and pay attention to them as well if you're checking your blood pressure at home. In the medical world, we use the term hypertension, but I wanted to make sure that everyone knows that hypertension is the same thing as high blood pressure. Why is it important that we're talking about high blood pressure today? It's actually very common. Nearly 50% of individuals in the United States, that is 122 million adults, has hypertension. So if you on this webinar are not personally affected by hypertension, there's a high likelihood that somebody you know, whether it's a friend, a coworker, family member, or a loved one, has hypertension, because it is indeed very common. We are concerned because there are no symptoms for hypertension, and the only way to know if you have high blood pressure is to have your blood pressure checked. So if you're checking it on your own or it's being checked in a doctor's office, outside of those two scenarios, we don't know that you have high blood pressure until you develop what we call end organ damage. So that's until there are complications of high blood pressure, untreated high blood pressure, such as kidney disease, heart disease like a heart attack, or heart failure, or even a stroke. It's known as a silent killer because of that very reason, because it is really without symptoms until it becomes pretty advanced. Now, some of the warning symptoms that one may have that their blood pressure is elevated include blurry vision, chest pain, difficulty breathing from heart failure. Also, if they've had a stroke, so impaired speech, maybe they've got weakness in the arms or the legs, or a droop in their face. So those are the symptoms of complications of hypertension. But pay attention to those other symptoms, such as a blurry vision, a headache, or difficulty breathing. There are a number of health problems. I mentioned consequences of high blood pressure, including kidney damage, stroke, as I mentioned, dementia, impaired vision, heart disease. Peripheral arterial disease is another one where there is decreased blood flow to the arteries in the legs. And we know that there are some actual pregnancy-related complications among women who have had high blood pressure during pregnancy. I included this slide because I wanted to draw your attention to the fact that, as I mentioned, hypertension is very common. It is often a disease of the aging, but we do have young people, as you've heard today, who have high blood pressure in their 20s or 30s for various reasons. In this slide, you can see men are represented in blue and women are represented in red. And you can see that the percentage of women who have high blood pressure is consistently lower than men until you reach that age of menopause. So about age 65 and later on in life, women are more likely to have high blood pressure than men, or at least they certainly start to match the percentage of men in the US population that has hypertension. Additionally, we see that there are some race and ethnicity differences when it comes to high blood pressure, in that Blacks, both Black men and Black women, have higher rates of hypertension compared to other races and ethnicities in the United States. And so this is something that you may hear when you see your clinician when you're talking about high blood pressure, is that they'll tell you that it is much more common in the African American community compared to other communities. Hypertension is important because it is a risk factor for heart disease. I included on this slide other risk factors for heart disease that are important to know because each one further compounds the likelihood of developing heart disease. So high cholesterol, specifically having high LDL or low HDL, tobacco use, physical inactivity, or obesity. And I think this is important because not everyone is obese, and that's not the only risk factor. Actually, not being active in and of itself is a risk factor for heart disease. Diabetes, as many of us know, and then of course, family history, specifically early cardiovascular disease. So a man in the family, first degree relative who may have had a heart attack or stroke before the age of 55, or a woman who had either of those conditions before the age of 65. And you'll notice I said heart attack or stroke because cardiovascular disease doesn't mean just the heart, it's the vascular system as well. So stroke is included in that. There are some risk factors that are unique to women that are important to talk about. And those include the development of diabetes during pregnancy, the development of hypertension during pregnancy. So whether it's just pregnancy-induced hypertension, depending on the week during the pregnancy that you develop it, or if you do have hypertension with complications such as eclampsia and in most severe eclampsia being the most severe form, and then preeclampsia as well. Polycystic ovarian syndrome, menopause, and then certain autoimmune diseases are also associated with cardiovascular disease, including lupus and rheumatoid arthritis. The other thing that's also important about autoimmune diseases is that we know that women who have lupus or rheumatoid arthritis, that they tend to have higher risk factors for cardiovascular disease. So we see higher rates of high cholesterol and hypertension in individuals who have lupus and rheumatoid arthritis. Not only are those risk factors present, but they're also not as well controlled as those who don't have lupus and rheumatoid arthritis. So we've talked a little bit about what hypertension is versus what blood pressure is and what blood pressure specifically is within the heart. So let's talk about what is normal, what's abnormal. Normal blood pressure is if you have a systolic blood pressure less than 120 and you have a diastolic blood pressure less than 80. It's considered elevated, and I like to use the word borderline with my patients. If you're between 120 and 129 with the systolic blood pressure, and still less than 80 with the diastolic blood pressure. Once we're above those numbers, it is considered hypertension, and there are different stages. So stage 1 hypertension is if your systolic blood pressure, the top number, is between 130 to 139, or the bottom number, the diastolic, is between 80 to 89. Stage 2 is if it's above 140, or if the bottom number is 90 or higher. And then there's severe hypertension, when the systolic is above 180 or it's above 120. And so when you're checking your blood pressure, pay attention to these numbers, because your top number, the systolic, may be 120, but if your diastolic is somewhere in the 90s, then you have stage 1 hypertension. And it is important to have that discussion with your clinician about what to do to get that blood pressure down. And we define people as having hypertension when we have checked their blood pressure at least on 2 separate occasions using 2 different readings. So if it just happens to be high one time, I wouldn't put you immediately in the category of hypertension, but it's certainly something that we need to continue to monitor to see if in fact you have hypertension, or if there was something playing a particular role on this day that caused your blood pressure to become elevated. So how do we measure blood pressure? That's the key thing. Now you know the numbers, but how do you acquire the numbers? Well, it's actually, there's a little bit of a science to it. First and foremost, you want to use a validated blood pressure machine. We'll talk about that on the next screen. How do you find one of those? But you don't want to be checking it, first of all, after you finish going for a walk, running up the stairs, or within 30 minutes of drinking coffee or smoking, because that can alter the numbers. You want to be sitting down, relaxing for at least 3 to 5 minutes. I tell my patients your blood pressure machine should be sitting exactly where you're going to be taking it. So I don't want you walking through all the house and then you sit down and take your blood pressure. It should be at that location where you plan to take it every single day. As I mentioned, you want to get the average of 2 numbers, so you check the blood pressure twice. You should be sitting in a chair where your back is supported, so you're not trying to sit yourself up, because that causes you to tense up and can cause your blood pressure to be high. We want your feet flat on the ground, and you shouldn't be talking to anyone or have anyone talk to you, because that's a little bit distracting as well, and you're thinking, etc. Between measurements. It's important that we get the arm supported, so your arm shouldn't be too high up or too low down while we're trying to get the blood pressure, because that can alter the readings and the accuracy of the blood pressure that we obtain. And most importantly, you want to get a cuff that fits appropriately, and your clinician can help you with that if there's any question. This is a great website here, validatebp.org, that provides a list of blood pressure machines that have been validated and are known to be accurate, that can be purchased over the counter, online, etc. I just went to one of the local pharmacies this weekend, and I found an Omron blood pressure for $37. So you don't have to buy anything super fancy that reads the numbers out to you and says it out loud. But go to this website and you can certainly find one that is validated and can get you accurate reading. As I mentioned to you, menopause is a time that women start to see changes in their overall cardiovascular profile and their increased risk for cardiovascular disease as well as hypertension. I mentioned that about 75% of women who are 60 years of older have high blood pressure. There are a number of reasons why we see this after menopause. One is that the decreasing estrogen levels causes the arteries to become stiff and causes the lining of the blood vessels to behave abnormally, which causes the blood pressure to rise. Those stiffer vessels in the setting of reduced estrogen release can cause the blood vessels not to dilate as well. So that also contributes to the constriction that results in high blood pressure. We all know that many of us post-menopause or our loved ones after menopause tend to gain weight, and it tends to occur in the abdomen, which is associated with increased risk for heart disease due to inflammation and insulin resistance that we find with with weight gain. And finally, in the postmenopausal woman, there's an increased sensitivity to salts. And where salt goes, water goes, and where salt goes, blood pressure goes as well. As Celina said, there are a number of things that can be done as far as lifestyle modification is concerned, whether it's changing your lifestyle with diet and exercise and, eliminating some unhealthy practices that are contributing to blood pressure. The key thing is that if you are identified as having hypertension, the first thing that we, the team, the clinician and the patient should do is really to institute lifestyle changes. And that should be done for about 3 to 6 months while you're being monitored, you're checking your blood pressure, you're going back to your clinician for follow-up visits, and then decide if you need to start pharmacotherapy, so medication. Now, there are some people with their blood pressure at that initial diagnosis is so high that they do need to start medications right away, in addition to some of these lifestyle changes that we're talking. This is from the 2025 hypertension guidelines, and I really just included this to show you, again, some of the lifestyle changes that are recommended. And that includes exercise, stress management. We know that stress, anxiety, poor sleep can contribute to elevated blood pressure, a low sodium diet, and then losing weight. For every 1 kilogram or 2 pounds that you lose, it actually lowers your blood pressure, the top and bottom number, by 1 point. This is a slide of just summarizing the DASH diet that shows a diet that has been shown to reduce hypertension when you adopt this diet. So it's low in sodium, higher in fruits, fibers, vegetables, low in alcohol, and fatty foods like fish or red meat. I wanted to include this slide because this is a summary of the impact of those lifestyle changes on your blood pressure. So if you were to lose weight, as I said, on average, those individuals who were put on a healthy diet, a low sodium diet, that if they had hypertension, it dropped their top number, the systolic blood pressure, by 5 points. But it actually even improved blood pressure for those who had normal blood pressure reading. If you follow that DASH diet, it actually can drop your systolic blood pressure by 11 points alone. Exercise, as you can see, can also reduce the systolic blood pressure on average anywhere from 5 to 8 millimeters of mercury if you have hypertension, by 2 to 4 points if you don't have hypertension. And then also cutting back on alcohol. In general, women should drink less than 1 alcoholic drink per day and men less than 2 drinks daily. And you can see the impact that has on your blood pressure. So imagine if you're doing a combination of these things, right? If you're following a DASH diet, you're really cutting back your sodium to less than 1,500 milligrams, you're exercising and you're cutting back on alcohol, you can have a significant impact on your blood pressure. And this is before we even get to medications. There are some classes of medications that are recommended and have been proven to be beneficial in the management of hypertension. So one class are the thiazide or thiazide-like medications. They're diuretics, so they help you to lose that sodium and water that travel together, that raise your blood pressure. And we like that because it's known to be quite effective and it's a good first line agent. Additional classes of medications include the ACE inhibitors or ARBs. So you may hear that class from your doctor, as well as some calcium channel blockers, which are known to work in both men and women and in all ethnicities and races. And so this is another good first line medication class. So usually these are one of the 3 agents we will start with to treat hypertension unless for some reason somebody has another medical problem, like if they have congestive heart failure, or if they've had a stroke, or if they have diabetes, then we may choose one of those other medications first. So I'm going to stop sharing and I will let you take it from here, and let's see if there's any questions that may have come in, or if you want to take it from
Awesome,
there with the questions you
awesome.
have.
Yeah, well, I'm going to sneak in a question before we get going into these other topics that you and I wanted to discuss, which is how do you deal with a patient who has hypertension, but is really, otherwise doesn't have heart disease symptoms and has done the 3 to 6 months of lifestyle modification and is still really hesitant to start a medication because they've never been on a medication that they have to take for the rest of their life before. So
Yeah.
how do you sort of advise them and get them over that hump or that barrier in their minds of I can't take a medication. I don't want to take a
Yeah.
medication.
Yeah. It's an excellent question. I face this every day in my practice because I think that there are several stages here. First, my
Yeah,
question to the patient would be, what is your concern? What is your fear? What is the barrier for you starting medications now that we've given it 3 to 6 months? We see that your blood pressure is not improving. We've sort of
yeah,
done the experiment, I like to say, on our own. You've done everything you can and your blood pressure remains high. So I start that dialogue so I can address what their concern is.
yeah,
And then, we talk about the potential complications. But before we even get there, one of the things we do say is I like people to sort of, I think one of the challenges is just wrapping your head around the fact that you have a condition and you'll need medication, right? Because you were fine for however many decades, and
yeah,
suddenly now you're telling me I've got hypertension. I feel fine, right?
yeah,
I feel
yeah,
great. I don't feel what you're talking about. And that's why it's called the silent killer. So I
yeah,
think sometimes it's just helping them realize that we've done all we can. The blood pressure isn't getting better. We can't deny it any further.
yeah,
Um, and that if we don't do anything, then we do risk the possibility of kidney damage, long term ending up on dialysis, having
yeah,
a stroke, having
yeah,
congestive heart failure. And the thing is, a lot of patients they'll know a family member who's had all of those things. And you
yeah,
don't want to end up there. And so, and we start small, right?
yeah.
We only use medications that we need to use
That's
to
right.
get it under control.
I think that that's a really key point that you said about, hypertension is not benign and it's doing damage.
Yeah,
It's doing damage. So it's not a number that is just, is kind of arbitrary. It's actually doing damage every day that you don't have it under those ideal numbers.
correct.
You also talked a little bit about how hypertension shows up in a woman's life at various points in her evolution, right? Whether it's pregnancy or a menopause, etc. So, how would you advise a woman as she is either preparing for these these big moments? Or, she knows, for example, that she's, in her 40s and she's starting to feel a little bit different, etc. How would you help her think about risks specific to heart disease and hypertension as she's beginning to go through these changes?
Yeah. No, I think you're right, just looking at the woman across their entire lifespan, right? So if we take pregnancy, first and foremost, I always say to my female patients, first of all, when I meet them for the first time, I ask about their pregnancy history. So did you have any of those complications that I listed there that are risk factors for cardiovascular disease, such as gestational diabetes or any form of hypertension?
Yeah,
And then if they have, then I educate them about that association with future development of cardiovascular
yeah,
disease. And what I mean by that is that women who have, whether it's eclampsia, preeclampsia, or pregnancy-induced hypertension, are at a greater risk of developing hypertension later on in life. So if you've ever had that during your pregnancy, that is a risk factor for developing it later on in life. If you don't have hypertension now and you have that history, That's something that all of your clinicians who are treating you need to know because they need to watch out for that. We need to be a close eye on that so that if you do develop high blood pressure, we're not just blowing it off like, why would she have that in her 30s or in her 40s? Well, because you had some pregnancy related complications. So that's
Yeah.
that. When I do have women who have had any of those pregnancy related hypertensive complications, I follow them very closely. We work very closely in conjunction with the obstetricians. So I follow them during their pregnancy. Even if they don't have it this pregnancy and they had it in a prior one, I see them every trimester
Amazing.
to make sure that their blood pressure is well controlled. I have them monitoring their blood pressure. We talk about what to watch out for. We talk about what the numbers are when we'll pull the trigger to start medications.
Yeah.
And their obstetricians are wonderful, and they're also starting medications. And
Yes.
then
Yeah.
there's menopause, as you said, is understanding that women may not have had hypertension throughout their entire life course. And then suddenly in menopause, when you're going through all of these changes, your estrogen levels are low, maybe you're not getting enough sleep, your cortisol level is high, which can also impact blood pressure, that we
Yeah.
see those changes. And so we talk about that and what things lifestyle wise we need to initiate, plus or minus medications.
Yeah, just thinking really about being, there's such a thing, right? It's preparing for menopause, preparing for pregnancy. And so
Yeah.
you don't have to wait until you have high blood pressure. You don't have to wait till you have symptoms, right? You know that these changes in your body are going to impact your body in a certain
That's
way, right? To increase the risks of hypertension. So I really love this idea that you can say, okay, I'm going to be forward thinking and I'm going to do these
right.
things in anticipation of. Also, you said something really important, which is you ask your patients about their pregnancy history. And I would also say, if you're a patient and you have that history, volunteer that information to any provider
Yes.
you see, because even if they don't ask you, it's important for them to know that, right?
Yeah. I 100% agree with you. I think we as clinicians need to ask more, but then the patients need to tell. But then,
Yes,
Celina, I think part of it is that we need to educate patients that about the association so that they can tell, right?
that's
If
right.
they knew, they would tell. And
That's
so
right.
that the onus is on us to do things like this, these talks, so that people can make those connections and we can continue the conversation going.
I'm going to go right into the next question, which I think is connected to what you just said, which is we know, and you talked about how some women are more impacted than others. For example, Black women or women with limited access to care, women in the rural setting, for example, is a good example of that. What actually have you seen help close some of these gaps?
Oh, that's wonderful. I think one of the things that came out of COVID is being able to have virtual appointments.
Yeah,
And so for patients, you mentioned rural
yeah,
communities. There are some communities in the United States where their access to a physician is maybe 2 hours away,
yeah,
right? Or there are not enough physicians, and so they can't get an appointment within several months if they
yeah,
find that they have high blood pressure at home. And I think something as simple as using home blood pressure monitoring, that's why it's
yeah,
important to get those validated blood pressure machines, is
absolutely.
that you can monitor it for me, send me a message, and based on that, we can make changes before you even come into the office. And then some places don't have doctors, but we have incredible partners in our nurse practitioners and PAs. And then
Amazing.
there are some hypertension run APP clinics throughout the nation and primary care offices that also have nurse practitioners and PAs who manage blood pressure quite well along with us. So I think those are some examples for unique populations that don't have access to care.
I love that. I mean, really, it takes a village, right?
Mhm.
It's and I often say like if you're waiting for the cardiologist to save or to like address all of your cardiovascular issues, that's going to be a really challenging situation given that we have in some areas few doctors, but way
Yes,
fewer cardiologists even, right? If you have difficulty accessing primary care, you're going to
that's
have
true.
a tougher time accessing cardiology. So having this team, you used the word team earlier, this team of providers and professionals working around you, I think is really important to seek that out where possible. On the note of lifestyle changes, um, when I saw your list, I was very interested in how those different changes improve your blood pressure. And I was overwhelmed when I was thinking about all of these things that I should, really want to be doing,
Yeah,
and thinking about all of them at the same time felt really overwhelming.
yeah.
So, do you like when you advise your patients, how do you advise them on sticking to it, right? Like being able to reap the rewards of making these really great changes in their day-to-day life?
That's a phenomenal question. It's one of my you didn't see this slide, but it is one of my takeaways is first of all, we're always thinking bite-sized, right?
Yeah,
It's like when we're trying to lose weight. If you say I'm going to lose 50 pounds, invariably we all fall off the wagon, we try again, and then you feel like a failure, which is not
yeah,
the way that we should envision this. We're talking about
right.
lifelong changes we're making. That's the way
Yeah,
to look at it. And so the first thing I'll ask my patients is, what do you think that you can easily do and be consistent with? Right.
that's
So if
great.
you are someone who eats red meat 4 days a week, you're never going to not eat red meat. So what I'll
Yeah.
tell them is I want you to cut down so where you're eating red meat once or twice a week, and then
Mhm.
we'll go from there.
Mhm.
If you are someone who eats out frequently, how about we change it where you're cooking at home? Make it fun. I say make it a competition like you're saving money, right?
Mhm.
So that's why you're not going
Yeah.
to eat out this week and see how much you can save. Compete with somebody else in the family or a good friend of yours. So thinking of innovative ways that you can tackle this. But I will say you just do one or two things per month. Do that solid for a month and then try something else so that you build upon your successes. And
Yeah.
any day that if you were exercising or you had a bad day, a rough day, I'm an emotional eater and you went out to go eat, that's today. Tomorrow's a different day. You're
That's
starting
right.
over tomorrow. Do
That's
not
right.
beat yourself up.
That's right. Yeah. You can every day is a new day, I often say. And my top tip is get yourself a dog.
Oh, I like that. Yeah.
Get yourself a dog. You will be walking a lot
That's
if you've got
right.
a dog if you've got a dog in your house. You also talked a little bit about measuring blood pressure. So if you go to the doctor's office and that blood pressure reading is high, what would you say? I mean,
Yeah.
that might mean that the person's nervous. That might mean that what gets written down in their chart is a high blood pressure. So how would you help sort of manage that situation?
Yeah, so I take into context sort of how they're feeling that day. So sometimes people run into the office, they're running late, and the blood pressure is high. So we'll recheck it before they leave to see if after relaxing for several minutes during the visit, whether their blood pressure has normalized. I'll ask them what they had this morning. Again, a high salt diet or a high salt meal can impact your blood pressure. So I'll take that into context. Did you just get into some people just may have had an argument with a loved one or on their drive over there, somebody cut them off, etc. But then we will say, if indeed I confirm before you leave today that it is high, if it's not extremely high where I feel like you're in danger that we do need to start medication, then again, then we will monitor it. But then first thing I'll ask you is, do you have a blood pressure machine at home? What kind do you have at home? And you're leaving my office with a blood pressure log so that you can write those blood pressures down and send them back to me in 2 to 4 weeks, depending on how high it was. On average, it's 4 weeks. And then we will make a decision if your blood pressure is high.
Got it. Got it. That really is helpful and very clear in addressing what do you call it? White coat syndrome? Isn't that what
White
they
coat
call it?
hypertension. So
Hypertension.
yeah, so that's essentially when your blood pressure is elevated when you're either in a physician's office or any sort of medical professional setting, but it's normal at home. And the way to diagnose that is if we check it outside of the office. And so that's why I always encourage my patients to have a blood pressure, because what's going to happen is that I can't rely solely on my readings. Now I've got to rely on yours at home because I know you're relaxed at home, it's not elevated. So if your readings become high at home, then we've got to pull the trigger there.
Exactly. Well, thank you, Dr. Isiadinso. I learn every time I speak to you. So thank you for this conversation. I do want to bring in Kina and Carrie, our champions. I've been a really poor timekeeper here, so I want to bring in Kina and Carrie. Let me tell you about these two women. Kina has been a Women Heart Champion since last year, 2024, and she joins us from Florida. And Carrie is, as she said earlier, from our most recent class, like 2 months ago. So she's brand spanking new as a champion. And we graduated, Carrie graduated at the Mayo Clinic this past October, and she's joining us from California. So thank you both. And Kina, I'm sorry we had a little technical difficulty earlier. But why don't we start with you, Kina, and talk a little bit about when you knew that you had some risk. What did that mean in terms of your family history, your pregnancy history? What were the factors sort of surrounding your risk around hypertension and heart disease? Oh, you're on mute, Kina.
Okay. Are you hearing me okay?
Yes, yes.
Awesome. So my pregnancy back in 2016, I was diagnosed with gestational diabetes. So at that time, I did monitor my blood pressure. Sometimes it would be elevated, but not most. And so I wasn't diagnosed with hypertension, during that time. Fast forward to 2019, where I was found to be in complete AV heart block. I was diagnosed with hypertension as well.
Wow. Okay. That's pretty significant, a significant diagnosis for you. So, and I want to ask this to both Carrie and Kina. Once you both were diagnosed, like how did you and your care team work together to manage your blood pressure on the day to day to make sure that it was controlled, that it was not causing you problems down the line? Carrie?
Well, thank you, Celina. I'll say early on, the first thing my primary care provider at the time told me
Yeah.
to do was lose 10 pounds. And because my own personality is one that was addicted to cortisol and stress and high achievement, I did it. I did that thing. I was like, okay, yeah, I can do it. And I went back, 30 days later or however long it took me, and it was still high.
Oh,
And so
wow.
I felt very deflated, like, okay, well, that didn't work, right?
Yeah.
And I see a question in the chat about being on medication. I just want to uplift the piece that was shared about accepting, like this is you're not a bad person because of it. You're not faulty. You're not like I will be on medication for the rest of my life. Have been on medication for over 20 years. That is just part of it. But you can work with your care team, if you have access to them, to find out which medication combinations are best.
Yeah. Yeah, that acceptance is key.
Mhm.
Did it take a while, Carrie, to get there or?
It did. And I would say that the majority of my learning and healing has happened just in the last 3 years because I then, 20 years into having hypertension, experienced a SCAD heart attack.
Wow.
And I've since learned that SCAD is associated with risk factors such as hypertension as well as migraine headache. And so I want to reveal again that there are potentially symptoms that the medical field hasn't identified per se as symptoms that are related to a certain aspect. And I'm not a medical professional, so I would just want to say I'm not giving advice or anything, but
Yeah.
those were signals to me that I was living a very unsustainable lifestyle. And so I've taken a lot of lifestyle steps. So diet is one, but not yo-yo dieting, right? Like I was trying to do that thing, but that did not work for me. Consistent eating, the DASH diet I've known about for a long time. Activity, super important. I do have a dog. She's a high energy dog. So we try to walk, multiple miles a day.
Yeah.
I don't do high intensity physical activity because that's not recommended with SCAD. And so but I walk her every day. And
Yeah.
I use that as my exposure to sunlight. I use that as my, mental health, like tension relief. Something that really stands out to me with hypertension, especially with women, is that the relationship between, and I've heard this in other webinars, the systolic and diastolic, and that the diastolic is at rest. We have to remember that as women, we don't rest enough. Like
Hmm.
it's just a metaphor for me to say
Hmm.
like, okay, I need to rest more. So
Hmm.
monitoring my sleep is really important and managing my own stress.
Yeah, I yesterday was speaking to a friend and I heard this phrase and I really want to own it, which is rest is resistance. And I just think
Mhm.
like, especially for women, like that's something to really sort of embrace and embody. I want to go to Kina. Kina, when you were diagnosed, like, how did you work with your care team to manage blood pressure alongside perhaps some other things that you had to manage? Was that a conversation that you felt was productive, or did you have to sort of find your way, navigate your way through to find a team that you really were able to partner with?
Well, I ask a lot of questions. I did get a new primary care physician,
Mhm.
just simply because I didn't everything just hit me at once, and so I felt like I should have been tested a little bit more, so or screened a little bit more during the time I had the gestational diabetes. We worked together. We came up with a nutrition plan, a fitness plan. I really did not want to get on medication at all because up until that point, I'd never been on any medication, long term.
Yeah,
And then I knew that once you start the blood pressure medication, oftentimes you can get off, but for the most part, depending on why you have it and the stage that you're in, you're probably going to continue to take it. And
yeah,
so that was kind of some hesitancy on my part, but my team, they work with me, provided information. My physician allowed me to call, in the evening sometimes with questions. And because I was diagnosed with to be in complete AV heart block at the same time, I knew the importance. And then with my background as well, I knew the importance of taking that medication.
yeah.
And so I can say that today, my blood pressure is managed. I've not had any issues since 2019 with my blood pressure. I do what I need to do. I'm on a very low dosage of the thiazide, but it keeps me where I need to be, and I've not had any complications.
That's fantastic to hear. Carrie and Kina, can you sort of think about your experience, and for the women who are on this call today, what's one piece of practical information or practical tip that you would encourage them to do this week to take action to make sure that they are managing their own blood pressure? Who wants to go?
I can. I
Okay.
would I would say definitely know your numbers, know the parameters, take time to put you first and
Yeah,
to understand a lot of times we tend to look at elevated blood pressure like it's not a big deal. But when you really look at what can become out of this, what, it can manifest into, you really want to take it seriously and just know your numbers and, take time, take your blood pressure. And even if you don't have any heart issues or high blood pressure, still have a blood pressure cuff in your home. Be able to check it in times of stress, be able to check and monitor your blood pressure.
absolutely. I know that the recommended guidelines for how often you should check your blood pressure is so low. I mean, in my mind, it's so low. Having a cuff at home is really critical.
It
Can,
is.
oh, sorry. Go ahead, Kina.
No, no, I was saying it is. You're
Oh,
absolutely
oh,
right. Yeah.
okay. Carrie, what would you recommend to our audience?
Yeah, I agree with Kina, knowing your numbers. I also just realized that Apple Health has a blood pressure monitoring feature. I know not everyone has access to devices like
Yeah,
that as well as the cuff. Get the cuff first. If you can't get a cuff, go to Walmart. Like there are still few places that have them, and so I'll do all three. I will take my measurements at home. I will quarterly go to my healthcare provider just for a BP check. And then I also will pop into Walmart every now and then just to check the numbers. But
yeah,
apart from that, I would also say address any other underlying mental health challenges
great.
in terms of stress reduction, lifestyle, stress management, all of those things. So spirituality, those things are very important. Yeah.
I really love that. The idea that you want to get to know what brings you peace, right? In
Yes.
our stressful life, And so you want to know where you can go and what you can do in the immediate term, right? If you are in a state, right? Like I know if I'm not sleeping well, that's going to impact my blood pressure, et cetera. So just knowing that I think is really important. Um, I know it wasn't a lot of time, but I want to thank Carrie and Kina for sharing your perspectives. I want to come back to Dr. Isiadinso. We've got some takeaway slides that I want to go over. I know we also have questions, and I thank you, Carrie, for saying we've got some questions in the chat. So we hopefully will get to those. But let's quickly go through Dr. Isiadinso's takeaway slides, and then we'll come back to questions from the audience.
Yeah, I will actually make it very quick because I'm
Great.
very interested in getting to
Yeah.
the question. So,
Good.
takeaway, hypertension is high blood pressure. As you've heard, know your blood pressure
Yes.
readings. When you go to the doctor, ask the doctor what they are. If they check it, you should walk out of there knowing what it is.
Yeah.
The importance of exercise and lifestyle changes. Exercise, you should be doing at least 150 minutes a week of moderate activity, whether that's 30 days, 5 days a week, or 1 hour sessions if you're at the gym twice a week is perfectly fine. It doesn't have to be done all at once. And women should do at least two sessions of strength training. Remember, start small. We're building, we're talking about lifelong changes and not sort of fast,
Yeah.
immediate uh, fad diets or fad kind of exercises. I'm actually going to stop there because I want to make sure that we have
Yeah.
time for
Let's
questions.
get into questions, and I see them popping in a little bit more. Kina did say one more thing I just want to really hit home. She said she changed her primary care doc.
Yeah.
Yes, I want to give everyone permission to do that, and I'm sure Dr. Izzy Dinza will back me up on this. If your doctor is not partnering with you to get results, you absolutely have the right
A
to go.
100%. And if it's not even just getting results, if you're working with a clinician, you feel like you don't have a good understanding what's going on, ask another physician or clinician.
Yeah,
I always say that you are entitled to a second opinion. I never take offense when a patient tells me that they want to ask someone else or see someone else because you're going to walk away with one of two things. Either that person is going to agree with what your clinician is already saying, so you've got a second opinion that agrees, or you're going to get a different perspective and a different approach to managing your problem.
absolutely. Okay, questions. I'm just going to quickly start. Can we get slides, Dr. Zedinzo? Is that okay to get slides?
Yeah, I can share them with
Awesome.
you. Mhm.
Great. All right, Joe, you're going to get slides. Annette, what about low BP? What is that a sign of? And just like hypertension, if diastolic is too low, but systolic is fine, should we also be concerned?
Yeah, I mean, there's a number of conditions. If there's some valve abnormality where the valve is leaking quite a bit, or if you're dehydrated, sometimes if the cortisol level is actually also too low, that can cause low blood pressure. So definitely that should be looked into if it's low,
That's
especially if you're having symptoms.
great. Is there a relationship between low thyroid and high blood pressure?
Yeah, actually, both high and low thyroid. So, low thyroid causes actually stiffening of the heart muscle over time and can cause the heart not to relax as well. And remember, diastolic blood pressure is during relaxation. And so that can cause that bottom number to be elevated.
Great. As fast as identifying high blood pressure, seeing lights flashing is a way of identifying high blood pressure. I'm not sure what that
Yeah, I
means.
don't know if I thoroughly understand that
Uh,
statement, but I think the person may be alluding to the symptoms of high blood pressure, which
got
include blurry vision, headache,
it.
shortness of breath, fatigue, etc.
Got it. Okay. Yesenia says, I always have higher blood pressure even with medication.
Yeah.
What should I do? I'm on two medications and don't understand why.
Yeah, I think that's where you really need to start working with your clinician because there are some people who have what we call secondary causes of hypertension, where they require a lot of medications to control their blood pressure. And even with that, the underlying cause hasn't been identified. And if that's identified and corrected, then they actually may see a better response to their blood pressure.
Great.
It's not often, it's rare, but it does exist.
It does exist, right? There's resistant hypertension, right? It takes some time. Mary says, HELP syndrome survivor in my 30s, later in life, effect on vascular. especially in the eyes. Interesting subject. Okay. Thanks, Mary. Susan says regular screening is the obvious solution to tracking health, but insurance doesn't often pay for this, or insurance is so expensive, it's a barrier to care. Even if women are regularly monitored, if she's monitoring her health, she can't always see a doctor who knows who to or know who to call. How do we overcome this issue of cost and awareness, and what's the best way to educate doctors and patients?
Yeah, that's a big issue, right? That's a system-wide, nationwide level, right? When you talk about the healthcare and that some people don't have access, as we said. And I
Yeah.
think the key thing is, again, is some cities and states actually have provisions for those who don't have health insurance or who need lower cost care. Here in Atlanta, we have Grady Health, which provides health care for people who are of low income at a lower fee. So I think understanding what's available within your city and state, and then more importantly, getting a blood pressure machine so that you can monitor on your own, at least until you find a clinician.
And Susan, I would also say connecting with organizations like Women Heart, connecting with organizations like ABC. There's so many organizations out there that are here to help, to get ideas, to figure out what other people are doing and how they're able to get their healthcare needs met, I think is really important. Catherine is a shout out. She's thankful, and I'm thankful that you were able to join us today, Catherine. And then one last question, right on the dot. Is it typical for readings to be higher for older women? And we know the answer is yes. Does the baseline for normal change as we age? Great question to end
That
on.
is a good
Baseline
question. So,
change.
yeah. So the baseline doesn't change per se. Normal is normal because we know that people in their 80s can have strokes and heart attacks, and we like the blood pressure to be low.
Yeah.
I do have a little bit more tolerance as my patients age because they don't tolerate lower blood pressures as well. So some of them might start to feel dizzy and fatigued if the systolic is in the 110s or 120. So it's very patient specific.
I hope the audience will join me in thanking Dr. Isiadinso. It was a rapid fire with Dr. Isiadinso and Kina and Carrie, but I want to thank you so much. I can talk about this, as you can see, all day long, but it is always an incredible privilege to talk about these issues that are really meaningful to women. You will see a lot more of this kind of content as we go into 2026. This is our last one for 2025. Have a really, really amazing holiday, and take care of your hearts during this holiday season. Holiday time is a really challenging time for us. So please, please, please take care of your hearts. Happy holidays, everyone. Happy New Year, and we'll see you in 2026.